I've just received my blood results and honestly, they're not great. So in this video, I'm going to go through what the numbers actually mean, what that means about my health, and whether you should consider getting your test done too. So before we dive in, a bit about me. So I'm a clinical prescribing pharmacist. So I've dealt with patients over the many years I've been qualified into interpreting lab results, treatments, and helping them assess and interpret what their health means to them. So when I discuss these results, it's not just about hearsay, it's about professional experience that I've gained throughout the many years I've been qualified. But also, it's not to scaremonger anyone, it's merely to empower people into taking better control of their health and hopefully deliver the information in a friendly manner. Now, this video will be broken up into two parts. The first part will be tests that you can normally get, whether it be on the NHS or through conventional labs. And I'm doing a second part where it's more about the advanced biomarkers that I've had tested. Both sets of results show really bad outcomes for me. So I'm going to display them transparently and we'll go through them. So the first is HbA1c, and this is used to measure your diabetic and blood sugars over the previous 3 to 4 months. Now, what it means is the amount of sugar that's attached to a red blood cell. And the reason we use this is when you can go and get a blood test in terms of a finger prick for your glucose level at that point, that's all it tells you. What is happening at that point. So if you've just had an energy drink with a lot of sugar in, or you've gone hours without any food, it will give you two different results. Whereas testing it over a 3 to 4 month period in one blood test gives you a better average and baseline. So the reason it gives you that is because once the sugar is attached to a red blood cell, the average lifespan of a red blood cell is 90 to 120 days. So it gives you that reading over that period of time. For context, I'm going to put up the results. So 20 to 42 is considered normal. 42 to 48 is considered impaired, or a term called pre-diabetic. And 48 and greater is classed as diabetic. Now, mine come back as 49, and it was previously last year 46. And there is a reason for this, but it still always gets me down. So I was diagnosed at the age of 10 with a rare form of diabetes called glucokinase modi, which, without going into the science of it, it basically sets my glucose level at a higher level than the average person. But when I do consume sugar, it will then allow insulin to react once it's hit this threshold, and then I will react in the same way, which is why it was quite confusing in the early days to be diagnosed. But I've tried a lot of things to manipulate this factor. So I have a low body fat. That hasn't really done too much. I've removed a lot of ultra processed foods, the only one being oat milk, and a few sauces if I ever go out on a meal in a restaurant. And I do a lot of exercise where I've now switched to more aerobic activity rather than the classic and generic weight building and bodybuilding that I used to do. But I've got to live with the fact that mine can be within a range of 40 to 60, and apparently is the only form of diabetes, as far as I'm aware, that doesn't come with the complications that normally is with a diabetic patient. And they are vision problems, kidney problems, and all the cardiovascular, which we'll go on to, such as heart attack and stroke. So what do I do going from here? I mean, there are always ways to improve my health and well-being through lifestyle. So I can always exercise to a higher intensity, which I will be doing. And in terms of diet, I've included a lot more fruit recently, so I've had a lot more dates, and I know it's sort of my sweet treat, but I'm going to have to remove them and see what happens over the next 4 months. So that's the first one, is HbA1c. So mine didn't come back as good, and it's been fluctuating between 51 and 46 over the past 10 years, as far as I'm aware. And before that, I actually don't know because it was all on a hospital system. Before we go into the next section, which is all about cholesterol, I just need to clarify a few things so that people understand why we test for cholesterol. Now, cholesterol, once it's transporting around the body, if it interacts in a certain way with the blood vessels, it can lodge. If you think of a sewage pipe, it can then build out and it reduces the size of the actual inside of the pipe. By reducing the inside of the pipe, you have less water going through it, and the same principle applies when it comes to your blood vessels. If you have your blood vessels which have become narrowed due to a plaque of buildup of cholesterol and other things, you have less blood going through it, which can then lead to heart attacks, stroke, anginal pain. So if we monitor your cholesterol, it can give us an idea, but it doesn't necessarily give us an exact risk predictor. Again, with a lot of things, you can put your seatbelt on, it doesn't necessarily keep you from any fatalities within a car crash or any injuries. It just reduces that risk. So there's another myth that I want to go through, and it's good and bad cholesterol. They are thrown around all the time. There is no such thing. Cholesterol remains the same molecule, whether it's doing a certain function or doing something else. And a lot of people demonize much cholesterol, and that's not what I want to get across. Without cholesterol, you will not be able to live because it is within the cell membrane of every cell, meaning that we need it for life. But if we have too much, like I've just said, and it's doing the wrong things in terms of how it's being used in the body, it can increase your risk of a heart attack. Cholesterol is considered bad, and I use that in inverted commas, if it goes from the liver towards the periphery, meaning if it goes towards a blood vessel and to muscle, adipose tissue, whatever it may be, because it has the ability to lodge within the arteries or blood vessels on the way there. And you have good cholesterol, again, inverted commas, when it's taken the cholesterol away from the sites towards the liver, but in actual fact, cholesterol is still the same. Now, bad cholesterol is known as low density lipoprotein cholesterol. In the UK, we aim for a value of less than 3, and ideally, we should be going as low as we possibly can, because the lower you reduce it, the better you have in terms of health outcomes. So for every number 1 that you reduce it by, you decrease the chance of a heart attack or stroke by 22%, which anyone would have that. So mine come back at 3.65. Again, it's been high for a long time. I have a family history of heart attacks and strokes from very young ages. I found out the other day an uncle on my dad's side had a heart attack at 27. My dad had 2 heart attacks at 50 and 51. His dad, his granddad, so on and so forth, all under the age of 50. So this is why it's always been a concern to me. How can I optimize these cholesterol levels? The next one is total cholesterol. So a lot of people will refer to this when you ask them about their cholesterol levels, when in reality, your total cholesterol within your blood is only 10% of actually what's in your body. So what you're seeing in the blood is only 10% of your whole body stores. Now mine come back at 5.9. Anything less than 5 is considered good. And that's one thing I want to discuss. Being good and optimal are 2 different things. If you are good, it means you may be normal within a certain population, whereas optimal is what we need regardless of all the other factors. If you have an optimal score in this, that is the ideal, but you could be good within a bad population. So total cholesterol, when it comes to reviewing patients as well, I actually don't take this as serious as other clinicians, because knowing how much cholesterol is there is one thing, but we want to know how it's moving around the body, which is where the risk actually comes from. And that is also in the second part of this video, because in the part 2, I go into the advanced biomarkers that gives us a better inclination as to how cholesterol is transporting and moving throughout the body. I'm going to go on to HDL cholesterol, so high density lipoprotein cholesterol, known historically as good cholesterol for the reasons I've said before, because it takes cholesterol away from the sites such as your muscle, fat tissues, and brings it closer towards the liver. That's the simplest way I can put it. In this one, this is the only one that you would ideally like a higher level, because it shows that we've got a higher chance of reversing the bad damage that's happened with the bad cholesterol, putting it within the vessels of blood vessels. So mine come back at 1.78, and mine's always been very good. Now, it's more complicated than just seeing how high it is. We need to know how it functions, but that's outside the remit of this video, and this is ongoing in studies to find out how you can determine the functionality of your HDL cholesterol. But the reason I brought mine up here is because the next blood test is called non-HDL cholesterol. And the reason we look for that is, like I said before, we have total cholesterol. So mine was 5.9. And then my HDL was 1.78. And whatever is left is considered to be what is giving you a high risk in cardiovascular disease such as heart attack or stroke, because they have the tendency to go from the liver towards the blood vessels and lodge there. So mine come back at 4.12. Ideally, we aim for less than 4. And for those who've had a cardiovascular event, meaning a heart attack or stroke, we try and aim for less than 2.5. And again, a lot of these things with cholesterol, we want it to try and be as low as possible, because we know within the human body that we can function at low levels, because ideally, when you need cholesterol the most is when you're in adolescence, when you're growing. The highest rate of growth is when we should have the highest level of cholesterol. When in reality, once you've grown, our cholesterol still continues to rise, which seems paradoxical. And that's why we want it to be lower, because then it reduces that risk of heart attack and stroke. Now, people might have heard of triglycerides. Mine, again, always come back as really good, 1.04. And the reference range is 1.7 and below in the UK. Now, I will put up the milligrams per deciliter equivalent for anyone who's in America, because that's what they use. We tend to use millimoles per liter or millimoles per moles for other units. So that's what I'm going off. So I will normally convert it on the screen. Now, the good thing about knowing triglyceride levels, triglycerides are a fancy way of saying fatty acids. So when you've got saturated fat, you have 3 fat molecules attached to a backbone, essentially. And that is the major storage unit of fat within the body, is a triglyceride. Now, the benefit to knowing triglycerides in conjunction with high density lipoprotein cholesterol levels is that we can determine how insulin resistant or sensitive you are at that one point. Because if you are insulin resistant, it means that you cannot use sugar as an energy source, meaning that we need to increase the amount of fats within the blood. And through a complex cascade, it means that the amount of triglycerides will increase and HDL, high density lipoprotein, will decrease. So in my case here, it shows that I'm not insulin resistant because my HDL is 1.78, which is greater than the triglyceride level, which was 1.04. If you have an inversion of this, meaning triglycerides were 1.78 and my HDL was 1.04, it would mean that my body is potentially insulin resistant. And it's just a slight marker that we can then use to go on in terms of further investigations. And you could then request an oral glucose tolerance test, and we would look into other formats and factors that could be influencing that blood result. Now, it was a whistle-stop tour. To summarize, my diabetic score was poor and has been for a while, and I don't think there's much I can do about that. I can obviously go on medication, which may enhance that, but like I said, I always try and optimize my lifestyle, which I feel as though there's always room for me to improve. And I will be doing that over the next 4 to 6 months and trying an increase in intensity in my workouts, reducing the amount of fruit, but replacing that with vegetables because there's less sugar. Now, in terms of the cholesterol profile, my bad cholesterol was high, and that's been that case for some time now, which is to be expected because what you will find out in the next video is that I have a high genetic risk of a heart attack and stroke because of the amount of people in my family that have suffered one at a young age. So that was to be expected. With total cholesterol, again, high, I don't necessarily look at that in its own right, but again, being high is not ideal in this instance. But my triglycerides and high density lipoprotein cholesterol were in the green, so that's something to take away from it. For anyone who has access to the NHS, you can get these blood results provided you've got a reason to get them. Like I said, there's been a lot of issues getting tested if you are a seemingly young and healthy person from the external side of things. So for me, for example, I would class as that. If I didn't have diabetes, I probably wouldn't have been able to get a blood test on the NHS. If you are able to get it, I would advise anyone getting a baseline, it's called lipid profile, which includes all your cholesterol, and HbA1c, which is your diabetic score. In the second part, which is going to be video 2, which is next week, I will go into the advanced biomarkers, which are not offered on a lot of national health systems. We offer it at our own testing service, which is the only reason why I have access to that information. And the results are even more shocking than the ones that I've just displayed to you now in terms of the genetic risk that I have for a heart attack and stroke. Hopefully this video has given you a bit more of an insight into what the blood results mean. Hopefully you've got a better understanding of how to interpret them and whether you should actually go and get tested yourself. By all means, it's like anything in life. Some people don't want to know. But if you want to prevent all these effects, such as a heart attack or stroke, 20, 30 years down the line, the work starts now, and there's no better way to start than actually knowing your baseline. Because like I've said, I would never have known the biochemical makeup of me if I didn't get tested. Looking at me in terms of physical and performance wise, you wouldn't think I'm unhealthy, but beneath the surface, this is what's happening. And now I've got many years ahead of my dad who didn't have this information to implement all these things that can potentially reduce the chances or even completely deviate from having a heart attack or stroke within the future. And that's what we're trying to do, is that these things manifest over decades, not minutes. So hopefully you'll come back for the second video and see the advanced biomarkers that we offer at our testing company, but also how they apply to me and what I'm going to do going forward.